Okay, good afternoon, everybody. Welcome to this public meeting of the Lancashire and South Cumbria Integrated Care Board. And can I very much welcome members of the public. You're always very welcome to our meetings, and we appreciate the time you take to give up to come here and listen to our conversations and our decisions. So thank you again for your attendance. Just to say, while I'm doing the welcome, I think people know that I'm the acting chair for the ICB currently. We do have the interviews this Friday for the substantive chair, and of course we will let people know as soon as that decision's been made and we can go public with that name. So you'll be hearing relatively soon who the substantive chair will be, and I wish good luck to those people who are applying for that position, and the people who are obviously sitting on the panel and taking that decision on our behalf. So thank you for your role in that. Apologies for absence. So I have apologies from Vicky Gent, Debbie Corcoran and Asim Patel. Are there any other apologies that I am not aware of that anybody knows? Any other to add to those? No? Okay, thank you so much. Okay, declaration of interest. Those are as listed, unless there's anything different to add to those that people wish to add at this present time. Please, as always, could you let me know if you do have a declaration of interest during the meeting, then that can be recorded in the minutes. Thank you. Okay, so item 4, we have the minutes of the previous board meetings of the 13th of March, the 10th of April, which was an extraordinary board meeting. Are there anything that anybody wishes to raise from either of those minutes? Nothing? Are we happy to accept those as correct record, both of those? Yes? Happy to approve? Yeah, thank you so much. So we have the matters arising and action log. So I'll go through those action by action. The research and innovation report, Sarah, is being proposed to come to a future meeting.
No, that's on the agenda today.
Oh, it is on the agenda. I'm sorry.
It's all right.
It's that, yeah, right the way down the agenda. It is there. Thank you. The tobacco-free Lancashire and South Cumbria strategy. David.
So an update has been circulated to board members.
Yes. Okay. Thank you very much, David. 7.7/24, children placed in appropriate settings. Sarah?
Yeah, thanks, Chair. I think for the next two, we were thinking of bringing both in July, if that's okay.
Okay, and health equalities.
Yeah.
Both to the July board.
Yeah.
Okay. Is that okay with everybody? Yes? Okay, thank you. The Blackburn with Darwin transaction for child and adolescent mental health services. We're proposing to close, and the transfer, of the adult mental health and adult physical health service provision. We received that report at the meeting on the 10th of April. We're proposing to close that. Happy to close that, colleagues? Yeah? Yeah, okay, thank you. And the last one is the urgent and emergency care recovery and winter update for 23-24. Craig, I understand that report is going to the June meeting of the Finance and Performance Committee, and then will be coming to the board in July. Is that correct? Yeah. We happy with that timetable then? Yes? Okay, colleagues? Yep, good. Okay, great. Thank you so much. That is all the preliminary business. We'll now move to standing items. I've got the Chief Executive, the board report. Chief Executive, thank you.
Thanks. Good afternoon, everyone. Normally have a quote in my report. This time it's not in English, it's in Te Reo. And having lived in New Zealand, and most of you haven't, I'll probably get away with the pronunciation. The good thing about Te Reo is they do use northern vowels, which is quite useful for me. But basically the quote is, "Ka hore taku toa I te toa takitahi, he toa takitini." which means we can't succeed without the support of those around us. It's about working together, isn't it? And it was never truer than it is in these challenging times. Just a few observations from the report. We're a new organisation. We inherited 8 different ways of doing things. There was quite a lot of variation, unwarranted in many cases, and appropriate in some cases too, across the patch, with variable service levels. We've obviously got significant challenges financially. We're going to have to do some pretty serious reforms. We've got to make some difficult decisions. And it's important in going through that process that we are patient-led and that we do listen all the time to our population. So I think it is appropriate to acknowledge the work that is done with our patients and our population day in, day out. I think as a board we've tried to embrace that by having a patient story at the beginning of our agenda. We've got a very big citizens panel which we use on a regular basis, and we've got a relatively new, I think it's been running for about a year now, a citizens health reference group. On the same theme, we can only deliver if we have our staff on board. They have been challenging times. That's meant a lot of change and uncertainty for our staff. And we do regular staff surveys, which are NHS-wide surveys. We also do local pulse surveys as well. The results aren't great. They reflect the challenges that staff are facing on the ground. So I think there's quite a lot of improvement we need to go through there. And the results are pretty variable. We've got some teams performing quite well and some teams not performing so well. So a big job to be done. It needs to be high on our agenda, and it is something we're going to return to, I think, as a board, to look at what we can do overall in that space. It's also about skills and capabilities and making sure that we've got our staff geared up for the challenges we face. We are working through a systems leadership program currently with a provider, and we want to make sure that that's a program that really does look at the real challenges that Lancashire and South Cumbria face right now, rather than being a sort of generic leadership program that could be any place ICB. It focuses on the challenges we face. We know that we're going to have to reconfigure parts of our clinical system. So what's the experience elsewhere in the UK and beyond, where it's worked well and where it hasn't worked so well? We know that because we have challenges on the financial side, we are going to have to downsize some of our activities. Who's done that well? What lessons can we learn from that? We also know that we have to shift to a more community-centric system, and again, what are the examples elsewhere in the country and beyond where that's been done well? And when you go through all of those things, we know that we've got to keep the public with us all the way through too. So who's doing that really well? So that's the sort of leadership program we want to develop, so that it's really directly relevant to the recovery and transformation issues that we'll talk about later. We are preparing a state of the system report. I think we've sent it out to all board members for comments now in draft form, so we will, I'd welcome your comments on that, but it is in your inbox somewhere. I'd like to acknowledge LSCFT. A little while ago they got their CQC good rating, but that's now been added to with a NHS England soft rating of 2, which is good as well. So well done to Chris, David, the board and the team overall. And finally, I'd like to mention the Work Well Vanguard project. We've been with our local government partners and others, we've got a significant programme there which can show how the NHS can make a real contribution to economic well-being and growth going forward. So would like to congratulate all the partners involved, especially our local government partners, but also our team who were involved with this, which was Andrew Bennett and colleagues in population health. It was a team effort. I think I've probably said enough. We have mentioned the award for the Cancer Alliance as well, with the HSJ Partnerships Award. I think that's worth noting as well, Chair. Happy to answer any questions if people have them.
Okay, thank you, Kevin. Any questions for Kevin on the Chief Executive's report? Yes, David.
Thanks for the report. It's always an interesting and good read. Thank you for that. There's a couple of points for me. On the section around engaging with people and communities, I mean, I think I need to commend the work that's going on. There's some really brilliant things happening. I do, however, feel like we could maybe strengthen the way that we hear the voice here. And wonder how we can do that. So, there's a danger that we put our engagement activity into a subcommittee and we don't really feel the full strength or hear the full voice of people as we make decisions here. So, where I've seen that done elsewhere, you would see a board paper or a business case come in that always covers what do we know from people, what intelligence do we have, what's people's lived experience. And also acknowledges when we don't know, when we haven't asked, because we haven't had time. So been really honest and open about have we engaged with people or have we not? And if we have, what have they told us? So that's the first point, just a suggestion really. And secondly, I was really pleased to hear about the leadership programme. I wonder, will that be opened up to the voluntary community and faith sector as well? Because clearly we're leading some of the organisations that support your activity. So will that be something that we'll be able to make use of?
Yeah, do you want?
You go first.
Yeah. The idea of the leadership programme is a system-wide programme. We have got some funding for 2 or 3 cohorts, I think it is, but it will require some funding from the other system partners as a contribution. It's so there will be a financial dimension to that, but we're basically funding it half as an ICB, so we will be looking to participate in organisations to put half of the funding in. But happy to talk outside. But yes, the idea is it's system-wide. It's not just for people in the NHS, because the challenges we face are system-wide, aren't they?
Thank you.
Yeah, thanks, Chair. I just wanted to respond to David's point about how we bring engagement and the voice of residents into the room much more strongly. And I'm conscious Debbie's not here, but we had a workshop for the PIEC committee a few weeks ago, and that also came out during those discussions. So there is work going on in the background to do exactly what you've just suggested, David, was at least strengthen how we bring reports through to show the amount of engagement that's been undertaken, but also to bring out the voice of patients and residents while we're presenting things.
Thanks, Sarah. Anybody else on the Chief Executive's report? No? No other comments? Okay, thank you for that, Kevin.
Thanks.
Okay, thank you. Let's move us on then. So we're back to you, Sarah, on the patient story.
Thank you. I'll just say a couple of words. So the story today is it's really pertinent to the agenda because it's we've got our digital strategy on the agenda, and also we've got our recovery programme, and I think this patient story covers both. So this is a gentleman who's living with a long-term condition, and many of our residents are living with multiple long-term conditions, and I think thinking about how we transform some of our services, particularly community services, to ease some of the pressure on urgent emergency care, at the heart of that is how we support people and who are living with long-term conditions. And what the story brings out is the advantage of having digital technology to support people who live with a long-term condition. I was a diabetes nurse for years, so worked with people often with multiple long-term conditions, and even the most self-sufficient people who are living with that need management, need support at times. And I think there's real opportunity with digital technology to really improve how we do that supported self-management. So I think the story brings all of that out today.
Hi, my name is Tom. I'm 57 and live in the Fylde Coast. I've got loads of conditions, but in amongst those I have a heart condition, heart disease. I did drink a lot when I was younger, and it's affected my kidneys, but I've also got heart disease. With my heart problem, it's important that the doctors keep an eye on my weight. If you put on weight, it can be a problem, and the doctors need to know. I've always found it quite daunting constantly visiting the doctors to have lots of checkups. I was referred to the remote monitoring service so they could monitor me from home, and they gave me a number of devices for me to use in my home. At first, I really didn't want to use the service. I've always been a bit of a technophobe. I hate modern technology and haven't really needed to use it in the past and didn't expect I would need to start. I actually think the service has been really good. They do train you so it's not complicated, and I think this is a good use of technology. I weigh myself every Monday and every Thursday. I do this at home so I don't have to keep going to hospital or to my GP. They've given me an app for my phone, and either me or my wife puts the numbers into the app. The information on the app gets seen by the hospital doctors, and they get in touch if they think I need to watch my weight. They gave me the equipment and show me how to do it. It's very easy to do. I know who to call if there are any problems, and they'll call me too. They will call me and give me advice and information if I need it. It's actually pretty easy to use, and I like that they are keeping an eye on me. Knowing that someone is down the line and they are there makes it easier. I feel a bit more reassured knowing that someone is checking the readings and will call me if there are any problems or concerns. They'll contact my GP and get in touch if things aren't quite right. I would recommend others to use it. It's still difficult living with a number of conditions, but this definitely helps.
Okay, thank you. Thank you for that, Sarah, bringing that to us. I am aware of that service in Blackpool and Fylde and the Fylde Coast, living in that area, and do actually agree it's a good service, and FCMS provide some good backup for that. So I think you'll appreciate the work that's going on there on the Fylde Coast in regard to that, and perhaps we need to look at whether that can be expanded to other areas of Lancashire and South Cumbria. You know, if it's a success over there, then obviously we want to replicate that wherever we can. Okay, thanks once again. Is there any questions, colleagues, or comments on the patient story? No? Okay, great. Thank you so much. Thank you again, Sarah, for bringing that to us. Okay, I'll move us back to the agenda. So, we're on to item 7, which is the reports from the committees, and we're going to start off with the Audit Committee, and that's you, Jim.
Thank you, Chairman. Nothing really I want to say. The alert relates to a comment made by the external auditors about how they will make a comment in the final accounts regarding our financial outlook, in effect. So I think we are aware of that, but it was highlighted in our meeting, so I'll just bring it through to the board. Other than that, there's nothing I want to add to what's written down there.
Okay, thank you, Jim. Any questions? Comments? No? Okay. I shall move us along then. Just bear with me 1 second. Sheena, I think it's yourself next.
Yes, thank you. So what I'd like to take members through is our AAA report for 2 meetings. The first of those is the 20th of March, and I'm going to focus particularly on the alerts, as I usually do in my report. So what you'll see is that there are a number of alerts. First of all, that I'd like to bring to attention about speech and language therapy waiting times. And this is clearly something that we are concerned about, alongside waiting times for children and young people for autism. And what we are looking at is the mitigations, both in the short term, which is around considering funding to try and mitigate some of those risks, but also I think probably more importantly is around thinking about the review of the end-to-end pathway and thinking about how we redesign this for children and young people with neurodevelopmental disorders or issues and how we can really start to address the challenges. You'll also see that there is mitigations around looking at the workforce plan. But what you'll see throughout today's agenda is that there are a number of themes that are being picked up. So you will see that there is action reported on in the performance report around children and young people's services, and also when we consider some other things in AAA report within the system recovery and transformation. So some of the key areas that we are looking at the Quality Committee we are now starting to pick up through the work in the wider ICB in terms of our priorities for this year. So I think it's a really good way of actually seeing that helicopter view about how all the different threads of what we do are coming together. The second thing I wanted to just mention was around, we have something that we consider at the Quality Committee, it's called the Quality and Safety Report, which takes an overview of a number of different metrics for our population. And the one that we were quite, I think, surprised about is probably the best way to describe it, and concerned was around some issues about life expectancy figures and some of those deteriorating across our patch. And that really relates to growing health inequalities. So we do have a Director of Public Health as a member of our Quality Committee, and they've taken that away to discuss at the Clinical Assembly in June to actually look at that bigger picture about inequalities and life expectancy. And what as a system do we need to do to address this? And that's clearly one of our key strategic objectives as an ICB. So that's something, if it's okay with you, Chair, I'd like to bring back to a report back to the board at a future meeting. The next alert I wanted to bring people's attention was some work that we want to do around looking at the learning disability health check. So again, later on the agenda, you'll see that we have improved the number of or the coverage of the learning disability health checks for our population. However, what we really want to check is the quality of those, because clearly it's, just doing a check per se, that's a good thing, because that person's is having those key metrics and the key things about how well they are looked at, but it's the kind of what happens next that's important, and how we join up services around people in an integrated way. So we're doing some further work, or asking for primary care to look at that. We have spoken before about the all-age autism and ADHD assessment bit, but the bit I really wanted to pick out next on that report was around the work we are also really shining a light on, which is children and young people with special educational needs and disabilities. So again, that's really something that we as a Quality Committee want to really see as a theme running through everything we do, around how do we ensure that those most vulnerable people get the best support that we can across our populations in an integrated way. We've mentioned before about primary care and the need to ensure that we have that look across the quality of that, and how do we consider that. And we are also had a really helpful report on the Valparate and what we're doing to ensure that we understand what we need to put in place for our population in really those safety features about prescription or prescribing Valparate to people. I'm going to then take you, members, if that's okay, down to the 17th of April alert. And the one thing I just wanted to pick out there really was around corridor care and boarding of patients. So these are people that when they come into the hospital system, unfortunately, because of the excess number of people that are now coming into hospital against how we have the resources to care for them in the way that we'd want to, unfortunately having some of their care delivered for a period of time in either corridor or boarded onto wards. Now, that is not great from the quality perspective and for people, but also it's not clearly a very good use of resources. So you'll see again later on in our agenda that in the system recovery and transformation plans, that is one of our top priorities, is to actually look at the whole of the urgent and emergency care system to seek to understand what's driving that, and then to address that, and to to work particularly in 24-25 to try to eliminate those two areas of care that we really is not providing the best experience or use of resources that we'd want for people. And I think that's really all I just wanted to pick out, if I may, from our AAA reports. Thank you, Roy.
Thank you very much, Sheena. I can say that a number of the issues you've raised there certainly resonate with me, and I'm sure with the rest of the board. In terms of health inequalities and life expectancy, we have some of the worst figures in the country in LNSC, certainly in Blackpool and surrounding areas. So I very much welcome you bringing that back, Sheena, at some stage. I'm sure, as I say, other members of the board will understand some of the points that you're making there, and I'm very glad that the Quality Committee has been able to bring those forwards and bring them to the board's attention today. So that's much appreciated. Thank you, Sheena. So I've got David first, and then Angie, and then Chris, and then Jim, in that order, please.
Okay.
I shall make a note.
So can I just correct the alert? Can I just correct the alert for the thrombectomy service, which is in the 17th of April report? The expansion of a 7-day thrombectomy service has been commissioned, but however, at present, the Trust is unable to recruit the workforce required to deliver it. So that is the key issue. The risk to patients is that we cannot provide the 24/7 service. Thank you.
Put yourself next.
Thank you very much, and thank you, Sheena, for making those links, which I think is really important. So I just wanted to pick up two issues. Firstly, to welcome the recognition on SEND, and I know we've mentioned this before, but as you know, the government are on the rounds of looking at SEND inspections. One of our colleagues in the area is undergoing an inspection as we speak. It's highly likely that a written statement of action will arise, which will focus on the ICB in that regard when they look at the areas. So getting a grip on this, I think, is really important, and driving it forward, because it does take out costs of the system later on, not to mention the life impacts on individual young people. The second point is a more general point. I was really struck by what appeared to be an increased number in alerts rising, and I just wondered as a board whether there's something that we need to reflect on, that is that the case, or is it just because we've got two sets of minutes here which makes it look like there are more alerts generally across the system. And then what assurances can we take on the board about how this is being factored into our risk management and our risk appetite? Because there might be some areas where actually we need to accept that risk and carry that forward, but there'll be other areas where, as is already happening, we're driving forward practice. So I just don't think we can just say we note this. I do think we need to ask ourselves the questions, is this showing us a trend which we need to respond to? Thank you.
Okay, thank you, Angie. We'll come back to that in a moment. Chris.
Thank you, Chair. And so it follows on really from Angie's point around neurodevelopment, and that whilst Kevin mentioned at the beginning around that fragmented commissioning landscape that the ICB inherited from the 8 CCGs, and I think this gives us a real opportunity, and it talks to it in the paper, doesn't it, about having ideally a commissioned pathway for 25-26, but it's that intervening 24-25 period that Sarah and I, and as providers, discuss it at our trust and ICB assurance meetings. But it's not to lose sight on the treatment as well as the assessment. And whilst we've got wait for 2 years plus for assessment, there is then an ongoing wait, which is equally as long for treatment, and the impact that Angie referenced around educational attainment, employment ability, post-education is really, really impactful, I think, and that there's no crisis of a child without that wider family, friends. So I think it's just for us to be mindful of that. Thank you.
Thanks, Chris. Jim?
Thank you. My comments relate to the patients and safety report items, and really it's very encouraging to read that all the never events were dealt with appropriately, and that the backlog of serious incidents has been greatly reduced. So we don't talk about this very often, but they're really important, and I think it's good to note that we're in a relatively good position, and there's no ICB backlog in this anymore. So I found it very encouraging to read that section, basically.
Thank you, Jim. Support on that.
Yeah, thank you, Chair. And my comments might respond or answer a couple of the queries. So I want to come in on a couple of things. The first one actually on the SEND inspection, because technically we are being inspected right now. So I was going to inform board that we are currently in the middle of a joint inspection on SEND, because the inspection of SEND is one of our statutory responsibilities. So Ofsted and CQC are currently in one of our places doing that inspection, and I'm obviously from leading that inspection for our perspective on Kevin's behalf. I don't think we can predict the outcome. Actually, from a health point of view, it's one of our less challenged areas when it comes to waiting times. And we've done quite a lot of improvement in that area, but we won't know until it happens. And of course, we're being inspected under the new framework, not the old framework, because the new framework's come in. So obviously, I'll keep board members. It started last week. Because what they do with the inspections, they do a lot of background work. The inspectors are in, so I'm meeting the inspectors on Monday, well, actually Thursday and then Monday next week. So it will conclude a week on Friday, and I will inform board members, obviously, as that goes on. But I think the point is it is a very challenged area nationally for all partners. And I think when I bring the report in July, there's an overlap really between learning disabilities and autism and children's and SEND. I will put a bit of a spotlight on that. Picking up on Chris's point, absolutely, Chris, I agree with all of that, as you know. I think it did say in the alert with the waiting times we were hoping to get a bit of resource. I can inform board that despite the challenges, we have prioritised through execs that we do need to address in the short term some of those very, very long waiting times. It's not just we've got volume, very huge volume of children waiting, and very, very long waiting times. So we have put a little bit of extra investment in for this year, but it won't address the longer run problem. But the teams are working in the background on that end-to-end pathway, which isn't just about diagnosis, it is about the whole pathway, and there will hopefully be a business case in the autumn that will go initially through CRG, and it may have to come to board. So I think it's a very challenged area, but I do think through Quality Committee and here board, we do see it as one of our top priorities, and we are trying to address those challenges. I think in terms of the alert, it's an interesting question. Quality Committee does oversee an awful lot of the statutory responsibilities of the ICB. It can vary from meeting to meeting, but a lot of core legal business goes through Quality Committee. So I think it's not so much that there's a rise in challenges. I think it's just that the business of Quality Committee is such that we are dealing with some of our very challenged areas. And that's why one of the comments in the alert was that we probably need a bit of a development time for board, because for board members who don't sit on Quality Committee, quite a lot of the business of the ICB, particularly around safeguarding SEND, learning disabilities, autism, it does go through Quality Committee, and I think it would be helpful, maternity, it would be helpful to have a more focused session with board members on that. And I think they were my main comments and responses.
Sorry, a few of the people indicated. I've got Jeff, David, Sam, and then Deb. Come back to Deb. Okay. Jeff first, thank you.
About worsening life expectancy and, sorry, I can put the mic on, worsening life expectancy and inequalities. And as some of you know, and I know we're in a maturing system, but I've always wrestled with the problem of the relationship between the Health and Care Partnership and its constituent sovereign members, like the ICB, County Council, etc. But inequalities goes beyond the responsibilities and the remit, the scope of this board. It's all the partners. And so when Angie made the point about, so we're making an alert, but what do we do with it? And I just wonder whether this is the sort of issue we should be informing the Health and Care Partnership, that we see this as a major alert around inequalities because of the life expectancy changes. And what does the Health and Care Partnership think all the partners should do? And it is within the strategy of the Health and Care Partnership to look at the life course events, and you know, and dying well is one of them, isn't it? So I just wonder whether, I don't know how you feel, as I say, it's an emerging sort of relationship, isn't it? But I just wonder whether this is something we should alert them and say, we're really concerned. Thank you.
David.
Thank you. I was really pleased to hear that we've got some work going on, and we'd discussed this in the Quality Committee around the corridor care and boarding, and you know that in the Quality Committee I was incredibly concerned about this. I'd never heard of boarding, so it was a new concept to me. And certainly some of the long waits that we've got in A&E, we were reported at a previous board. I think we had 150-hour waits been reported for a handful of patients. So I guess I've got a level of concern about that, and I'm just really keen that we work hard not to become desensitised to those matters. You know, it's appalling, and I know there's lots of work going on, and we should support that with everything we've got. But it simply wouldn't be good enough for my parents to be cared for in a corridor or held on a ward until there was a bed available. So really supportive of that work and the ambition to kind of alleviate that within the next year. Thank you.
Thank you, David, for that. Sam?
Yeah, and that's when we come on to it a little bit later, we'll be talking a bit about that in the recovery and transformation, because that has to be a focus from both a quality and a financial perspective, but the quality is a really important leading part of that, really. My comment was just really coming back to Angie's point as well, and around the alerts is, and it might be what Deb wants to pick up on actually, but I'm pretty confident we've now got a much more robust risk assurance framework in place, and the board assurance framework is working pretty well, and that's been supported by both our internal and external auditors in terms of the progress and update on the work that's been done during the year. I think what does happen at committees, as well as the alerts coming to the board, is we do have a regular review of the risks that are pertinent to that committee at every committee. So we go through in the committee and review those. So we're keeping it very live. And then in terms of the session with the board and bringing our risk appetite into that, we will be doing that in the board session that's planned in June, because we've got a June board development session around the board assurance framework, having an oversight of that. So we'll be regularly looking at that. But I think the number of alerts might look a little bit more, but I know behind all of that there is a proper process that's in place that's working quite well actually. So hopefully in our board session we'll have a bit more time on it.
Deb's conceded to Sam. Thank you. Okay. No, I think Sam's covered the points that Deb wanted to make. I don't think anybody else has anybody else indicated? Oh, sorry. Yes. No. Okay. Do you want to come back at all on any of that, Gina?
No, I mean, I think very useful comments. Thank you very much. And you know, what I think we are demonstrating through the Quality Committee is the fact that we are ensuring that quality is absolutely at the centre stage of everything we do, and that all the programmes of work that we are developing, particularly in the delivery plan for 24-25, are very much grounded in what are the key things that we feel are the really tricky risks that we were looking at through the Quality Committee. So it's really just to kind of sort of put that final sort of framework around it all. Thanks, Angie.
Okay, thank you very much everyone for all your comments on that. Very important piece of work. that is going on, and lots of work going on in the quality committee, so thank you for that, Sheena. Okay, we're over to Jim for Finance Performance Committee.
Thanks. There's two meetings to just quickly talk about. It's interesting reading the March notes now how events have overtaken a lot of it, so I'm not going to say very much about that at all, other than we did make reference to the use of virtual wards being very low, and that's being looked into, and hopefully we'll be getting an update on that in the next Finance and Performance Committee. And we also mentioned that we're going to review the terms of reference of the committee. It's not so much the role of the purpose of the committee, it's around the quoracy arrangements, and that something needs to come back to the board around the quoracy to make sure that we can work effectively. Everything else has been basically overtaken by events. On the 29th of April, we were still talking about this year's projected financial position, and that conversations were ongoing. Sam may well update us on that later, but I know conversations are still ongoing, so that's not finalised. We've got a large QUIP programme for this year of £220 million. There was a comment about palliative care, about the reduction in the proportion of people identified and recorded as being in the last year of life. That's something I think we need to be looking into as an ICB. One LSC is progressing, but there's still some issues around the, certainly the timetable has slipped, and there's some things still to be resolved on that. And there's a general comment on the alert section there about sickness absence rate. As an area, we've got a higher sickness absence rate than both the regional and the national averages, and it's why and what we're doing about it. It was kind of the comment being made by the Finance and Performance Committee. So I'll leave it at that.
If it's okay, can I pick up the palliative care alert here? Because I know it's also featured in the performance report. But you're quite right. It's really important we get palliative care and end-of-life care correct. And if we do so, we get the best possible deal for the patient, their family. And in fact, obviously we want to make sure that the patient dies where they wish to be, if possible. And we certainly don't want patients just ending up in an ED department dying there. So there is some work that's ongoing. And what we're doing, there's two things. First of all, working with Craig's team, we've now are appointing a number of commissioners for palliative care. They should be imposed reasonably soon. But also we've been working with Marie Curie, who have a programme about moving to excellent. And it's about developing a plan for us for palliative care, so that over the next few years we can move and remove that variation that exists across Lancs and South Cumbria, so we can be a better place to care for our patients and our population as they move towards the end of their lives.
Okay, thank you, David. Anybody else? Oh, sorry, Deb, yeah.
Can I just raise a point of accuracy on the minutes that are published from the 29th of January from the Finance and Performance Committee? And it's under page 2 of those minutes. I think it's page 100 in the pack, where it should refer to Jane Mellor as the UEC lead.
Okay. Okay, the minutes are all included in the pack, as you're aware, so we'll ensure that that's correctly changed. Thank you. Thanks, Louise. Okay, thanks again, Jim, for the F&P. Anybody else on the F&P AAA reports? No? Okay, thanks once again. For the Primary Care Commissioning Committee, so the AAA report is as read. I'll take that as read. If there was anyone at that committee who wishes to comment on anything that was raised there. If not, I'm just going to ask that we note those at this present time. Is that okay, colleagues? Yes, thank you. I'll move us on then to Jane O'Brien and the People Board. Jane, thank you.
Thank you, Chair. So at People Board, we looked at the staff survey findings across all NHS providers in Lancashire and South Cumbria. Kevin has mentioned the ICB staff survey results. So I think it's fair to say there were similar themes across the system in terms of disappointing but not surprising themes around staff morale, particularly I think in relation to embedding compassionate leadership cultures. So we felt as a People Board that this is an area we want to focus on, and further work to look at how we receive monitoring data from our providers on what improvements can be made to that. The other significant development for the People Board is we've revised our terms of reference and membership. The People Board is focusing on system-wide working and how we support our workforce to undergo the transformational change needed for the ICB to achieve its objectives. So how we bring about the change in the way people work, change in emphasis from acute care to kind of more community care, and looking at how we work together across the system associated with that. We've established that the People Board needs to be strategic in orientation, but we have 4 working groups that we are establishing to undertake some of the more detailed implementation work. The areas that they cover are education and training, culture, system leadership, transformation, and wellbeing and inclusion. And again, for all of those, we want participation from all organisations across the sector. The last thing we looked at as the board was the workforce strategy, which is on the agenda later today.
Okay, thank you, Jane. Any comments, questions for Jane? Yes, thank you.
It's just a quick one. So just in relation to the point about achieving the objectives for the ICB, it's also about, isn't it, achieving the objectives for the wider system partners as well, attending the board.
Yes, sorry, just to be clear, by the objectives, I mean more the sort of aspirational aims for the ICB, which are about addressing health inequalities, improving social and economic outcomes for people, and value for money, an emphasis on population health, and what's the 4th one? Somebody tell me which one I've missed. And there's another one. But that's what I meant, sorry.
Yeah,
I didn't mean organisational aims, I mean the wider aims of our integration agenda.
Thank you.
Thank you, Kath. Anybody else? Thanks again, Jane. No, nobody else. Okay, that's for noting as well. You'll also note on the agenda that Debbie should be here for the Public Involvement and Engagement Advisory Committee, and unfortunately Debbie, as I said earlier, is not able to be with us. There was also, I think, a seminar on that particular committee as well. I don't know if any other members of that want to raise anything. If not, I'll ask again that we note that report today. Is that okay, colleagues? Yes? Are we happy? Yeah, thank you so much. I'd just like to mention as well that the minutes of all the committee meetings are attached and have been circulated with the agenda. What I would propose to do in terms of expediency is that next time we have those minutes as a link that are on the board papers. Therefore, if you wish to access those minutes, then you can do that through those links. Is that acceptable to the board? Are we happy to agree that? Yes. Okay. Thank you so much. Sorry, I shall move us on to the integrated performance report. Unfortunately, Asim is not able to be with us either today.
Craig.
So we've got Craig. Have we got Craig? Okay, thank you, Craig.
Thank you, Chair.
Thank you.
I'll do my best to give you the highlights of the performance report. I'm not going to go through this page by page, which I'm sure the board members will be pleased to know, but I'm just going to bring out some of the highlights that Asim would have wanted me to draw your attention to. So just in relation to what the data covers, this is mainly February and March's data included in the report, so not April's data as of yet, but I have got some up-to-date information that's not published, but I will mention to board members regarding April. In relation to urgent and emergency care, I am very pleased to say that our 4-hour target, which of 76%, was met by the end of March by 0.5%. So we did deliver the national standard of 76%. As we've mentioned lots of times, for many of us, that national standard when it was in the 90s was something we wanted to have ambition to achieve. So this is not being complacent, and we are already in the month of April exceeding the current national target. So there is an improvement already, and I just wanted to let board members know that we are currently around 16th in relation to the ICBs in achieving that target. So our current four-hour data that's unpublished puts us 6th out of 42 best in England as well. So I think that's something to be proud of. However, I want to ensure the board that we are still working on a huge amount of interventions to look at the whole of the urgent care pathway. So this is not just about our performance in A&E. As we know, Sheena mentioned a number of other issues that impact on A&E, pathways, corridor care, boarding, etc. So whilst we are achieving a national target here and we're doing quite well compared to others, we've still got a large job to do for the improvement of our urgent care pathway, and that'll be something that comes up in our recovery discussions later. In relation to context, we did see 13% more attendances though in March this year compared to last year, and we met the target. In relation to elective care, it's remained similar to previous months, but our most recent data in April shows that we've seen a reduction of around about 1,500 people on our waiting list. So whilst started to stabilise, we have started to see some improvement. We're looking at more of the detail with regards to some of the specialities, because there is variation, so oral surgery, gynecology and ENT. So there's some of the areas that we are looking to focus on. In terms of long waiters, the number of 65 plus week waiters has been falling for the past 3 months, so that's going in the right direction, and the overall percentage of the overall list size that are waiting over 65 weeks puts us in a very favourable position in relation to our national performance. With regards to our 78-week waiters, obviously there is a zero tolerance for this. We did have 39 at the end of March 24. This related to significant pressures in orthodontics and oral surgery, which we are aware of, and it's one of our remedial set of actions. In relation to cancer, we did meet our faster diagnosis standard, which is one of our metrics, and we were slightly short of our 31 days standard. One Trust did meet that, and if we can see one improvement in One Trust overall, the aggregate position will put us in a positive place in relation to Langston South Cumbria. We didn't see any of our trusts, though, meet our 62-day standard to date, so that's some further work that we need to do with each of the providers. And just finally, before I open it up to questions, primary care, we have been reporting throughout the year that the volume of general practice appointments per head per population is well below the national average. So the ICB here for the weighted head per population for appointments in general practice is 4,266, and the national average is 4,919. However, when you go down into some of our places in more detail, one of our places is only seeing 3,785, so even within that lower level, in particular places, there's even lower number of appointments. Now, that does have a direct correlation to our workforce in general practice. So the average number of GPs per 10,000 population is just over 5 for Langston South Cumbria, and nationally it's just over 6. So that's almost a GP different per 10,000 population. But again, in one of those areas where we saw the significant reduction, we're only seeing 4 general practitioners per 10,000. So it does directly correlate to those available appointments. But again, some further work that we'll be doing, and we are going to bring back a deeper dive into primary care and its improvements at a future board. So I'll pause there, Chair. I appreciate there's a huge amount of information in the integrated performance report. It does come to Finance and Performance Committee for scrutiny, but I'm happy to take any questions from board members.
Thank you for taking that on behalf of Asim, Craig. That's much appreciated. As you said, there's a huge amount of information there and data. So I'll take questions. I'll take Aaron first.
Thanks, Chair, and thanks, Craig. It's just on the UEC performance. I think it is something to recognise in terms of colleagues that have worked really hard through a tough winter and then continued some of that real focus on driving improvement through March and April. But it does come with some caveats. You know, 76% or above, 77, 78 as a stretch isn't where we want to be, and we just heard through feedback from various colleagues about corridor care, boarding on wards. So having that performance presented as it is, it comes at a cost and some consequence in how we're trying to manage the urgent care demands currently. I think what it places for me is much higher stakes and much higher priority on the urgent care improvement work that we'll do through the recovery and transformation paper that Sam's going to present later on the agenda. And it's really understanding what we can do over the next 6 months to try and get ourselves into a much better position as we enter the next winter period. I am concerned. I was on a regional leadership group with Kevin this morning about reflections of previous winter and a general perception that it was potentially not as tough as we were anticipating. Some things in our favour. We can't plan for that this winter, so we need to get a real jump, Chair, on the next 6 months recovery work under that programme.
Thanks, Aaron. Sarah.
Thanks, Chair. It's not a question. It's more a comment, I suppose, to build on the earlier discussions, particularly around children and SEND. And the challenge around children's waiting times is you don't have to report in the same way. So I think the paper at 3.10, Asim and I have talked about this, does bring out the community waiting lists, which are harder to report. But again, you know, children, you know, we were asked to have a name lead for children, which is me. If we think about inequalities, our children are our most precious commodity, aren't they? Because they're our future. And one of our main priorities is better start in life. So whereas over 18 weeks, I know 52-week waiting lists are falling in adults in community, they're rising in children, particularly in speech and language therapy, and I know it's over 400. That's a lot of children. The neurodevelopment waiting lists that we've talked about aren't even reported any of this, and that gets into the thousands of children waiting very, very long waits for those to access those services. So I do think it's really, really important as a board through these reports that we see the whole picture and the challenges and not just the things that we kind of have to report up through. So I am working with Asim on that in the background. But again, I think when we do that deep dive, I will bring out some of the stark statistics on those waiting times so that whole of board is cited on that challenge.
Thank you, Sarah. Tracy.
Thank you, Chair. Yeah, just a couple of observations, really carrying on from what Sarah said, but thinking more in terms of what's said here under 4.5 around waiting lists and the fact that they're increasing. We've done some work across the voluntary sector looking at kind of waiting well, and I think it poses as an opportunity to think about whether we can release some of that system pressure, because obviously when people are waiting, they're going to put pressure on the system later down the line. And there's some other examples across other systems where interventions from the voluntary sector when people are waiting for treatment actually can result in people not needing that treatment in the future anyway. So again, I think, you know, we're maybe not exploring all of those opportunities. And there has been quite a lot of work done over the last couple of years with a number of partners across the voluntary sector looking at that potential of supporting people as they're waiting so they can improve in their health and build on some of those health creation areas that we were talking about. And the other area really as well is specifically around flu vaccinations. Within this report, there's information about a low take-up amongst deprived population, Asian populations. I wonder again if some of the lessons that we learnt from COVID around those vaccinations we could apply, where we really mobilise those culturally appropriate organisations in the community who can really improve the uptake. Again, thinking about the prevention, thinking about the positive consequences this could have later down the line for people if the take-up of flu vaccination improves.
Jeff.
Yeah, as you'd expect, just to talk a little bit about primary care performance and you know, the whole nation is suffering from a difficulty in primary care. I think we all know that. Increasing workload, decreasing workforce, decreasing funding. And a lot of these are beyond the shores of the ICB, aren't they, with national discussions and the BMA calling for a new contract. Some interesting comments coming out from the BMA now about actually trying to define what is general practice supposed to do, because it's not well defined. So that in itself creates a problem. So we'll see where that goes, but I think we need to be alerted to the fact that that performance is maybe the wrong word. The outcomes are not looking great, but individuals and practices are, I believe, performing very well. But the capacity they have and the workforce they have doesn't allow them to look like they're performing well, just because of the lack of resources. So I do wonder. I'm sure David and your team, you're all over this, but there's a sense of a need of priority discussions within the ICB about what is within our power to do to support primary care, because there are real risks emerging over the last year or two, and we need to be alert to that and show some understanding and support to our primary care colleagues, whether that be general practice, dental, pharmacies are struggling, optometry. So I think we need to look at the whole thing, and I dare say we are, but I think we need to say that. I think we need to say it publicly as well. I know it's going on behind the scenes.
Well, best respond then, hadn't I? So, Jeff, you're right, and I think we hear a lot about the hospitals, and we can see there are challenges there, but the similar pressures apply to primary care. And remember, these are often smaller organisations that are much less resilient. And we've seen through the quality report already at this meeting the concerns raised about quality issues in primary care, sometimes simply because the pressures are so great. So we are taking it seriously as an ICB. Both Kevin and I are meeting with primary care representatives to understand the challenges, and we are seeking to do what we can to try and improve the resilience of our primary care, working with the local medical committees where possible.
Okay, I don't think anyone else has indicated. I'll come back to Craig if you have anything to say to any of those. No? Anything to comment? No.
I think David answered Jeff's question. No, just absolutely. David and I work in tandem on primary care from a clinical and operational perspective. And I think Sarah's points on maybe what's not being reported is pertinent to what we need to make sure the board has sight of in the future, because I think we're right, the community element isn't as easy to capture, and then within that there are elements. So I think having a more detailed discussion on some of those topical and thematic areas of the future would be helpful, Chair.
Okay, thank you. And we also note Tracy's comments on the voluntary sectors and the opportunities that are enabled there for us to take in terms of helping our population, and especially our deprived population. So thank you, for those comments, Tracy. So we're asked to note the performance against the key performance indicators and to support the actions being undertaken to improve that performance. Is that agreed, colleagues? Yeah? Happy? Thank you. We now have the finance performance report at month 12. So, Sam, thank you.
Thank you, Chair. So this is the report at the end of last year, and I know we're now sort of in May and looking back at last year, it is important we just acknowledge the end of the year position. As reported at month 11, when we were forecasting the position, we reported a likely position at the end of the year of £148 million deficit, and that's after £80 million of support funding. So really a position of £228 million deficit. So it is a significant deficit for the system, and it's one that's having a huge amount of focus by all of us in the board and in our senior teams and across the organisations. I suppose what isn't in the report, and we've had some discussion in the private part of the board about this, is just to be really clear about, you know, sort of why did we set a plan of 80 million deficit and we've ended the year at 228, because that's a significant change. And you know, when we look at this across the country, the mandate for the NHS, we have to stay within that budget nationally. So anything that changes in one part of the system has to be compensated somewhere else. So it's really important that we understand why are we here and what do we need to do about it. And I suppose both this paper and the next paper are important to take sort of one after the other, because there is a huge amount of work going into the recovery around here. So if we look at what we assumed when we set the plan at the start of the year, it was largely around when we were, as we went through COVID, we put in an awful lot of additional temporary capacity. And that capacity took the form of a lot of additional staff, additional sort of escalation beds, staffing in ED, and certainly in the UEC pathway and in the urgent care pathway, that was a large part of that. The assumption at the start of the year was that's temporary. COVID's now moved on. We should be able to shut some of that down and de-escalate some of that. That has not been possible, and we've just heard today of some of those pressures that we've been seeing in the reports, and we're going to talk in a minute about this sort of the corridor cares and the UEC pathway, but the demand for that and what's going on in our ED departments is huge, and it has not been possible to step down that. So that's been a big part of the assumptions we made at the start of the year, and then why we haven't been able to deliver that, and the trusts haven't been able to take those costs out as we've gone through the year. The second part of it has been a really big significant hit on our continuing healthcare budgets. We are one of the highest spenders of continuing healthcare in the country, and we have a significant hit this year on inflation and on new packages, and that has contributed to a bigger pressure in the ICB books. So both of those two things are probably the highest, sort of the biggest areas of contributors to our deficit position. But what I would say is that we are putting lots and lots of work in around this. And when we moved into the autumn, that level of risk that we saw in not being able to take the capacity out and seeing those sort of pressures on our CHC led to a reforecast. And the organisations, every organisation in the system, have worked extremely hard to land where we said we would be at the end of the year, and that's where we've landed. And we're working very hard now on a position and a plan going into next year that is lower than where we've ended this year, with a real plan to move back into recurrent financial balance. So we're working that up as part of our recovery and transformation plans. I think that as we've moved through the year, there's been a huge amount of actions, and every single person in the system, every trust and organisation have been working together to look at how do we put additional grip and control and really scrutinise our expenditure to make sure that we're adding value in what we do. We're not wasting and we're not duplicating costs, and that's been a big focus through the control environment we've put in place. We've also tried to understand why we are an outlier on some of the things like CHC, and we've brought in reviews from other systems into that, and we've been reviewing and benchmarking and getting behind that. But under the leadership of our Director of Nursing, Sarah, we've brought that service together into one place because we had multiple models of CHC across the system, and that hasn't been an easy job, but it's been a good piece of work that's not just brought everything back in line and actually taken some of the waste and duplication out, but it has also seen significant quality improvements, not least the 28-day waiting and getting quicker assessments, and that's been recognised by our regulators in terms of the good work that Sarah and the team have done. So all of these things have not been taken lightly. There's a huge amount of work, and I think when we look at that and we look at everything that we've done over this last year, despite this being a really horrendous deficit position, you know, there was a lot of delivery also happened, which was why I think we talked about it last month. You know, the amount of SIPs and particularly the recurrent savings that were made by every organisation this year has been higher than it's ever been, and that recurrent nature is allowing us to put in a position that will be improved from this current year as we go into next year. And I think that's as good as we've got at the moment, but we are still working really hard on it, and it's not something we're taking lightly, and it's certainly something that we recognise is not a place we want to be. I think it's just really trying to now understand how do we drive those costs out that we're seeing that are really being pushed by the pressures that we're seeing, particularly through the UEC pathway, because we wouldn't want this from a quality perspective, but we certainly don't want it from a finance one either. So that's what will take me into the next paper when we get there, Chair, but that's probably all I want to say at this stage. Happy to take any questions.
Yeah. Thank you, Sam. Questions, comments? No? 1-12. Thanks for all the work to finance and your team, Sam, and yourself for the position. I know it's difficult. Had a really difficult year, I know, but you've pulled together and really done some exceptional work, I think. So please pass on our thanks to the whole board, to the team, for the work that they've done on that and bringing us to where we are currently. Thank you. And to the trusts, of course, as well. So that is for noting that report. Unfortunately, it's you again, Sam, on system recovery and transformation. Thanks again, Sam. Cheers.
So this paper is I've taken on the role of recovery as part of my role from April this year, and this paper is setting out really the progress that we've started to make around that. And what we're really trying to do now is say, well, how do we drive ourselves out of this position safely? And it's really important that we do this safely. It's very easy. Anybody can balance the books of an organisation if you're just prepared to cut the quality and we're not prepared to do that, and neither are we, you know, ignoring the money. So we need to get the balance right here, and this is about doing this in the right pace at the right time and getting the right outcomes for us. So the paper sets out the approach in 24-25 and beyond for recovery and transformation, and it details, I think in section 2 we go through in detail some of those pressures that we are facing, some of those challenges that are impacting on our financial position. You know, we've got in there the ageing population, the definite impact, and I think a disproportionate impact in some of our areas of population from COVID on health inequalities and the widening inequalities we're seeing as a result of that. The impact on demand on UEC and on our mental health services and the unwanted variation, the workforce, and then leading to fragile services. And I think, you know, all of these things are impacting on our position. So, you know, it is a very challenged system. And these things have been well reported and I think understood by a lot of people. But what I'm doing currently is making sure that we have a really clear understanding of that position through a really good set of diagnostics to say what is the one current version of the truth that says this is where we are and this is. So what is it? Why are we finding ourselves with such massive demand coming through ED and in terms of additional admissions as well? So we're seeing both are, you know, in the early information that I'm seeing, it's showing that both pressures and admissions are up much higher than we're seeing nationally. So we need to understand that. So we're doing some work to really understand the drivers of that, what is causing that, what is it that we can do to start to change that and to reduce those costs. So as I described in the finance report, we didn't deliver the savings that we were expecting in relation to that capacity in the last year, but we did start some really good work on long-term transformation to ensure that long-term financial sustainability. And that's included the work to develop a clinical blueprint and services to support the business case for the new hospital, and also looking at the One LSC in terms of a corporate platform. All of those things are in train and working, and they are the programmes that are progressing in the background. But the Recovery and Transformation Board met on the 22nd of April and agreed a much shorter and medium-term focus around recovery, focusing on that UEC pathway and reducing some of that excess unfunded costs in UEC pathway and in mental health. And the Recovery and Transformation Programme will focus now on 3 key areas that will all be progress concurrently, but will work at different varying timescales in terms of what we need to do. The first one is around waste and duplication, and it really is taking waste and duplication out through our SIPs and equips. That's things like better efficiency, productivity, better procurement, more grip and control. We will continue to do those things. It's good practice. Why wouldn't we? We want to get the best value for the taxpayer and our public purse. So we are going to continue with that and continue with all the work that individual organisations will do on their own. But we're also, the second part is going to be, so that's the first part, the second part is going to be improving the quality. And we really do need to focus on the UEC pathway to look at what have we got in terms of escalation beds, corridor care, fragile services, looking at that whole pathway and making sure that we're connecting the whole pathway. So this isn't just about looking at our providers, this is now engaging with our place directors, thinking about the transforming community care, thinking about the out of hospital offer and connecting it together, because that's what's going to be really important through this, because we will drive that quality. That pressure on corridor care, escalation beds, mental health out of area placements and pressures and additional staffing through the ED pathway is costing us over £80 million. And it's not great, is it, to have people sitting in corridors or not able to get out of hospital quick enough. So we have got to focus on this from a quality perspective, but it's costing us an awful lot of money, and this is where we're seeing a lot of our pressures. The third and last area is the transformation and making sure that we continue with that clinical blueprint, the single corporate platform, the focus on good quality services, and creating Lancashire South Cumbria as a great place to work for our workforce. And we need to do that through a real transformational lens. So all of those 3 areas need to go hand in hand together. And as I say, there will be different timescales on each of them. The waste and duplication is immediate. We will continue to work on that. The improving quality around the UEC pathway needs to be this year and the next, and transformation will be over the next few years, but we'll be doing them all together. So business as usual waste and duplication, SIPs and QIPs are really high this year. We are going to have to put in, to meet our plan going forward now, a significant level of SIPs and QIPs, and again for this current year. But I think with the recovery programme supporting that, it is deliverable, but we need to all work together. But there's a lot of risk in that, but we need to work together to get that delivered. And there's an element that trusts and providers can deliver themselves through all of that, but there's definitely part of it that will need a whole system response, particularly the de-escalation of UEC pressures and OPEs. And so therefore we'll focus that through the recovery. The ICB QIPs are largely going to be around centering on that CHC prescribing and contracts and commissioning, so we've got those in plan, and we've developed a really strong process behind the SIPs and QIPs and commissioning intentions and recovery, bringing that together through some very strong processes now that we've got sort of developed across the system. So the diagnostic work that I've talked about will drive the metrics, and what we're going to have, we've got the first recovery programme board tomorrow, but we're going to have regular review of each of our programmes using very clear metrics with trajectories and those being monitored at Recovery Board, and also in assurance meetings. We have monthly assurance meetings with all our providers. So the Recovery Board meets tomorrow, and it will be developing over the coming weeks and holding all of those programmes to account with regular reports back to the board. Place alignment, it will be important in this, and our place directors have a key role in the work they're doing to align with because the work that they are working on is absolutely relevant to this whole agenda. So we need to think about how that connects in to the recovery work. And establishing the programme leads and the governance, there's a few gaps in that still need to be worked up, but they should be sort of smoothed out over the next couple of weeks. So that's where we are on recovery and transformation. It's a bit of a stock take tomorrow of where we are with everything and a reset of the programme. So happy to take any questions.
Thank you, Sam. Very clear, absolutely. And note that the System Recovery and Transformation Board has now become the System Leadership Oversight Group. I hope it isn't much of a slog. That was what it's... Okay, hope. Okay, I've got a few people who've indicated. I'll take Chris first. I think it's Chris and Jim.
Cheers, thanks. And it's not really a question, it's just really to support the approach. I think, you know, having mental health in there as an urgent care improvement, I think is really good. We know the experience, the poor experience that people get when they're receiving their care out of Lancashire and South Cumbria, but really the huge financial cost that comes with. So fully support that, the improvement lens that I think Sam's brought to this, and just the conversations that myself and David Fillingham have had as Chair and Chief Executive of the Mental Health Trust with local authority chief executives and council leaders around that commitment around not cost shunting, but actually looking at what's best for the populations that we serve. I think this all comes together. It's really good, really supportive.
Thanks. Mine's just comments as well, really. The first thing is, I think this is a really good piece of work. So you got it to a really good place. We need to take it forward. Obviously, the proof of the pudding's in the eating and all that sort of stuff. But just on behalf of the board, the Finance and Performance Committee is going to look in as much detail as it can into the detail behind this, because it's very complex. It's very detailed. We can't have a full discussion on this in the board setting, I guess, because it would just take too long. So outside of the board, the Finance and Performance Committee will try and kind of sift through this and make sure we've got assurance around the deliveries and so on. So the Recovery and Transformation Board, which is kind of system-wide, it is really helpful. From a board perspective, I think hopefully the F&P will do some of the heavy lifting around kind of assuring that we're delivering what we should be delivering and when we're delivering it.
Thanks for that, Jim. Aaron.
Thanks, Chair. To echo Chris's comments, I know this builds on the work that Maggie Oldham have been leading, but you can see the development and how it's moved on at pace over the last month or two to put it into a shape that I think all chief execs at the provider board, and I would imagine most leaders who've had a chance to look at this, would support as a direction. I think there's some things in here that we probably need to strengthen as we move into delivery phase. So I think there's something in the vision and the collective narrative that we put as a group of leaders in the system as to why this is now important and what we're trying to do to release resource and get joint commitment across the system for delivery in this way. Sam's point about quality and safety are paramount, they're red lines, and we need to address the financial challenges. What I can see though is even when you have proposals put forward that do have some solutions around answering the financial problems we have and still retain quality and safety, we're still too slow to get to delivery and decision making and execution, even when the solution is clear. So there's something in the accountability framework that sits around this and holding partners jointly to account on how important we all hold in this, where does it feature in your respective organisations' priorities, how are you putting your best resources forward, because what we're saying across those 5 or 6 programmes is it touches every part of the system. The second bit is it's connected in the recommendations, which is that trajectory now. So not just for this year in terms of SIPs and QIPs, but the other recommendations that we've got in here around soft rating, CQC, quality improvement, partners improvements. If we've got that 3-year ambition, it'd be really good to see year 1, but what does the next 3 years look like, and how do we maintain the pace and momentum of commitment to these programmes, knowing that we're ratcheting up, I'll call it a Blue Peter thermometer type analogy, where you can see the contributions to that end point where we can get to the position that we're needing to. But really supportive from the provider collaborative. It's been jointly designed and produced with Sam and the team. Looking forward to kind of launching, mobilising and resetting and getting the teams right on the pitch now.
Yeah, Just a couple of comments. Really commend the work. I think it's a really good piece of work, and I think, you know, the point there that it's been done with people, so that this co-production I think is really important. And as we move forward, I think we need to continue to focus on doing that. Absolutely agree about this is about really needs that focus now on delivery. So it's the how do we bring this to life, make sure we do that. And then the third thing I just wanted to say is, in a similar way to Jim's describing that finance performance will have an oversight of this, we also have agreed now that we will have a feed through to quality committee as well, so we can keep that assurance around that, which will also be around actually how do we help with the delivery of this as well. So I think we all need to, you know, do our best to make sure that we enable this to happen, and to move forward positively, but with that assurance and oversight as well. Thank you.
Nobody else? Just welcome Jim and Sheena's commitment for both their committees to be able to help in the delivery of this. David, did you want to come in? Well,
if I may, so it's really helpful, I think, just to remind the board that we've heard about the financial challenges the ICB and the system have, and Sam is describing, along with Aaron, the clinical solutions to that financial problem. We know we have too many services in too many places and too few staff, and that does have an impact on quality. So what we need to do is look at our services, and actually what will unfortunately come back to the board is sometimes some difficult decisions to be made to ensure we can provide services safely to our population.
thank you, David. Okay, nobody else, as I said, indicated. Sam, just a question from myself. I was wondering whether it was worth us thinking about, and you might take this back to your group, of a system and transformation dashboard. We already have obviously a business as usual dashboard, and I think it might be helpful maybe if that dashboard could come back to the committees that Jim and Sheena have indicated, but it would be really helpful to show progress on system and transformation, and I think it would be an indicator to the board about how that has been progressed through the work that's going on. Thank you, sir.
Thank you very much, and we will be doing that. I'm very fortunate that I've got some very good people around me in the team working up some very good sort of templates and metrics and things that we're going to be sort of using to feed the assurance framework and the committee. So we will be doing that, and thank you for all your comments. That's really, really kind and very helpful. Thank you.
Thanks once again for the work that's going on. Okay, I'm going to take us on to the they're all for approval. Hopefully I will take them as read. Obviously they've been circulated with the papers, so I would ask the presenters of each of these items to be as kind as possible in their presentations to help us to understand, of course, the items themselves, but be possibly as brief as possible as well, if that's okay. Thank you. So I'm going to take the 5-year workforce strategy first.
Thank you, Chair. So this is just a really exciting piece of work that has started life in July last year, almost a year in the making. And as Jane alluded to earlier, it has been to our people board. This is the first time we have had an integrated workforce strategy for Lancashire and South Cumbria, so it's a real step change for this locality, and it's something I'm personally very proud of. It's been such a privilege to engage with over 200 partners, members of our community, in the development of this step change approach to developing a one workforce ethos. As Sam's alluded to already, this is also a really integral part of supporting our recovery and transformation programme, particularly around opportunities for workforce transformation, reducing bank and agency spend, reducing corridor care, and actually thinking about our suitable and sustainable talent pipelines for the future, because that's a real key issue for us. We know we have an ageing workforce, and just as an example, there's also a bigger train coming down the tracks over the next 3 years. Nationally, there is a 22% reduction in nursing applications, so we know in 3 years' time we will have less nurses coming out. So actually, using this strategy and a one workforce approach will be a real step change for us to prepare for that journey. it has come up with and developed 6 high-level strategic objectives around developing that one workforce approach. And as I say, this is a real step change. It's the first time we've actually had an integrated health and care workforce strategy that will absolutely start us on that journey of that one workforce ethos and moving and working together to improve care for our patients and communities of Lancashire and South Cumbria. So I will pause there, and I'll just ask Jane, though, for any final comments, who's been on this journey with me and the People Board, before we open up to any questions and reflections.
Well, thanks to Lee and his colleagues for the strategy. And I think People Board was particularly appreciative of the fact that it has been co-produced, and there's been extensive engagement with all agencies across the sectors. Excuse me, I've got a frog today. It's not ideal. Just a few points from me. It talks about one workforce in this strategy, and it's a little bit like an exam question. That what does it mean, one workforce for Lancashire and South Cumbria? And we can debate it for hours, and clearly it's not one workforce in the sense of we all work for the same employing organisation, particularly across the sectors. But I think where it does have traction is thinking about where can we work together as one team to define what kind of employee value proposition we can offer to workers across our system. What can we offer them in terms of good standards of recruitment, health and well-being, training, education, career development? We can work as a system on that. And it can be something that we can identify with our area as something we can work on collaboratively. And I think going forward in implementation, that's something we really want to encourage. The other aspect for implementation is around the transformation agenda, how we support staff to change and to develop new skills in line with new ways of working. My third point and final point is one about good work. If we offer our employees good work, that has much wider benefits for our population than just the delivery of health and care. Good work is good for people. If we're recruiting from local communities, we can start to address issues around deprivation and poverty and health inequalities and support that agenda around economic development. So good work and working together will meet kind of a health and wealth agenda for our population, which I think is really important. Thank you, Chair. That's all for me.
Thank you. Thank you both to Lee and to Jane there for those comments. They're well received. I've got Sarah first and then Tracy. And
yes.
then David.
Thanks, Chair. Just a couple of comments from me, I suppose, just to support how important a robust workforce strategy is for the system. I don't think we've had a focus on workforce specifically at the board for a while, but actually, we've just heard Sam talk about transformation. For me, this is the triumphant bit, because our workforce are at the heart of everything we do. And if you think about some of our challenges, our quality and cost challenges, if we can't recruit to a certain group of our workforce, that leads to poor quality, either because we have gaps and patients wait a long time, or because we use temporary staff who actually the evidence is there that you don't get the same quality. But also, when you have those gaps, it costs us a lot more because we end up paying a kind of inflated rate. So the workforce is just pivotal to so much of our transformation. But also, building on what Jane said, we want to recruit from within our local communities as part of our answer to some of our population health challenges, and we want to retain. It's all part of that, building the economy as well. And all of our services are some of the biggest employers across Lancashire and South Cumbria, so it's so important we get this right. I think also, and I think it's in there in the strategy, it is about being more flexible and innovative in our thinking, though, because some of our traditional way of doing things, so we heard earlier about speech and language therapy and long waits, even if we want to recruit and train more, that there's a gap to that, so we have to find different ways of working across the professional boundaries, but also across specialties. And I think Tracy wants to come in, there is a massive opportunity to work more closely with our voluntary and wider sector on some of these workforce challenges. So I really support this piece of work, and we need to make sure it drives the work that we need to do around the workforce, but also it's pivotal to our recovery and transformation over the next few years.
Thank you, Chair. Yeah, I want to start with a thank you really, Lee, to say on behalf of the VCFSE Alliance how engaged we have felt in the process of pulling together this strategy, how you and your colleagues have come along to assembly meetings and really work with us to co-produce elements of this that really involve our workforce, and how really probably for the first time it feels like a workforce strategy that's inclusive of the VCFSE. I also, want to definitely pick up on some of the points around developing a workforce from the communities across our areas. But specifically, I think something that has struck me as we've talked about recovering transformation and right at the very beginning of the meeting where Kevin talked about the Work Well Vanguard and Jane's comments that I really welcome around the connections between health and wealth, how it's almost as if part of what we're doing here is pulling together all these pieces of this jigsaw, and Work Well is particularly relevant, I think, when we talk about this agenda, because I think we've got opportunities with that investment to really look at how, as an employer, all the partners around this table really work with our workforces to keep them in work. We've got lots and lots of really unsatisfactory sick absence right across all of our partner workforces. And I think, when we look at the objectives of Work Well, we're talking about helping people to stay in work. We're talking about people being able to go back into work after illness and disability. And that is, the onus, a lot of that is on employers. And I think we've acknowledged as we've worked on this submission for this funding for the Work Well Vanguard that actually there is a gap around working with employers, and I think it starts with us, and I think we've got to be exemplar in the way in which we support our workforce to remain in work, and I think some of that really poses opportunities around this. So again, Lee, and the invitation there to come and work with us in terms of how we are rolling out some of that work in communities, supporting them so that actually we don't find that somebody signed off sick means they're going to be long-term out of work, because we all know that poses challenges right across our system. And when we look to the future and we talk about what we're trying to achieve with our elderly population, we want to keep people in work and keep them healthy as long as possible.
Thank you. I just wanted to say, really supportive of the strategy. It was a good read. It was easy to read and understand. It left me thinking about just the fairness and equality kind of aspects of with our workforces. So obviously, if you work in the local authority or NHS, have those as employers, the terms and conditions and pay and benefits and opportunities often outstrip what's available to people that work in the third sector. So I think we just need to consider that carefully. We want to obviously act as a feeder for you. So lots of the staff that work in my organisation come and end up for your organisation, come and work for your organisations, and we support that and encourage that and want them to grow and thrive. So I suppose there's just a plea from me in your commissioning responsibilities as organisations to really think about making sure that you invest properly in the contracts that you ask us to deliver on your behalf. Make sure that we can pay fair and equal wages, and make sure that we can give the benefits that staff need to keep well and stay well. Thank you.
Thank you, David. Absolutely agree with those comments. I've got Jim and then Aaron. Jim first.
Thanks. Thank you for this. It feels like it's the start of something, start of a journey, this. And I was reading this and I'm thinking, okay, what will things look like in 5 years' time? And I can't pin anything on this, basically. So I'd like to see possibly some deliverables and some endpoints through this, which will actually give us something to work towards. I think it also needs to consider the question of affordability around some of these plans as well, which would be helpful. But I'd like to see some tangibles. If it's possible to build tangibles into this. I don't know whether they're scheduled to come out of the implementation plan. If that is the case, then we could do with know when the implementation plan will deliver those tangibles, just so we can be aware this is taking us. Sarah made the point, and I'd written it for myself on my papers when I was reading this. This is our biggest threat to service quality in the service. So if we don't get this right, then service quality is going to go down the pan whatever we do. So we have got to get the workforce issues right, basically. So this is a really important strategy, but I'm not quite grasping what this is going to do to make things different.
Okay, I'm just going to bring Lee in before I come back to you, Aaron. That's okay. Lee.
Thanks, Jim, and thank you for the support of that. Absolutely take your point. This is a start of a really exciting journey. The Reform People Committee that Jane referred to earlier, those subgroups, then we're working up those implementation plans, so it will be more clear. So the actual next meeting of the People Board will be to review the Year 1 implementation plan, and I will ask for it to come back here. So actually, it starts to bring that to life for you a bit more, so you can actually see that, and board members. So absolutely take that point, but that it will be addressed to the implementation plan.
Aaron.
Yeah, thanks, Lee. Yeah, another good piece of work. Similar line of inquiry to Jim, so I won't repeat that because I think that would really strengthen kind of the confidence and assurance around the strategy being able to be delivered. For me, it's about simplifying the strategy. It's very similar to the digital strategy that follows. It's a big chunk to take in one. So if you've spent a lot of time with groups, with colleagues, with partners on designing this, it'd be great if we could use it, I don't know, with a strategy on a page that really articulates what this is about, what's it intended to do, how do you get engaged with it, maybe as part of our recruitment processes. So if you're looking to join the service or join our partners or join the system, this shorter document would be something that would make you want to come here and work in our system. So yeah, an offer I think with the CPOs as well to work on something around that, but yeah, really support the piece of work.
Thanks, Aaron. Again, really welcome that. I think for me, absolutely the simplicity of this, a plan on a page, really in terms of this is a 5-year strategy. It will be a Year 1 implementation plan. We can't do it all at once, and actually involving the CPOs, provider collaborative, health and social care partners, as well as our voluntary sector, what this means for people, so everyone's very clear what we want to deliver in Year 1, because some of this will take longer, but actually when people can see it and engage with it, and our local communities can see what the opportunities are as well, it brings to life everything I've talked about. But thank you for your comments, and thank you for everyone for your feedback as well.
Okay, thank you, Lee. Thank you again to everyone for all the comments. Very clear, everything. It's here to approve, colleagues. Are we happy to approve that people strategy? Yes? Is that agreed? Yes? Okay, thank you. Sorry, as I said earlier, unfortunately, Asim is not able to be with us. We have Stephen Dobson with us as well, but I'll just bring in the Chief Executive first to make a few comments before we bring Stephen in. Thank you.
Okay, some strong parallels with the previous paper. This is a strategy about the whole system, our population and patients, first and foremost. Two key themes here, really. How we use digital technologies to transform our health and care system, and how we promote convergence of systems and processes over time as well. There are 4 priorities in the paper: a single digital infrastructure, a single core platform, single data architecture, and a single service delivery model. So that word single keeps coming up. It means a joined up approach to delivery fundamentally. In some cases, it is about a single digital system, such as an electronic patient record. Our aspiration is to have a single system for that in the future. In other cases, it's a single approach which might be delivered by different brands and products that are interoperable. So there are different ways to do it, but where essentially those products do talk to each other. It's about best practice, it's about standardization, and it is about eliminating unwarranted variation. Again, it's building on a lot of stuff that's been done before. So I just thought I'd highlight 3 things. The first is the Digital Northern Star, which has been working for a number of years to move towards a single way of doing things across Lancashire and South Cumbria. It's supporting and building on one LSC, the new corporate platform and vehicle for delivering corporate services. And in that regard, actually, Steve Dobson is the digital lead for Lancashire Teaching Hospital, but he's just also been appointed the digital lead for One LSC, and it's a big and important dimension of that area. And it's also building on the shared care record we have in Lancashire and South Cumbria. It's one of the things we're well known for as well. So there are some strong foundations there. We don't want a digital strategy that's sitting in splendid isolation from the wider health and care system. And I hope it comes through in the papers that this is very much connected to our core business of reducing inequalities, improving health outcomes, providing the best care at the right time in the right place, etc. And it's also connected to the wider health and care system, feeding through the integrated care partnership. And I think also it was very timely and appropriate patient story this morning, and actually we've seen other patient stories at this board where lack of technology has caused issues. So I think it's very relevant to all of that. The next steps for this strategy, building on Jim's theme at the end in relation to the workforce strategy, is to now develop system-wide and place-based delivery plans and investment plans to translate this vision into what we're going to do over the next 3 to 4 years. And in that connection, the Chancellor actually did announce a very significant financial package as part of the budget, which was 3.4 billion investment in digital infrastructure for the National Health Service. So there are going to be some very significant opportunities. That will be handled, I'm not sure of the precise terminology, but we do have effectively a digital board that will look after all of that process. So I've probably said enough, but I'll pass over to Steve Dobson, who's been one of our leaders in this space. Steve.
Thanks, Kevin. Thanks, Chair. Kevin started this meeting today by saying we can't do this without each other, and this strategy has been several years in the making and is born out of collaboration. Digital Northern Star was written about 2.5 years ago. It advocated that shared infrastructure, shared corporate and clinical systems, shared data to meet our clinical operational needs, and we've got a rich history of collaboration right across the ICS, particularly in digital. It's also about removing complexity. Today, each of our provider trust manages several hundred clinical systems, and all of the myriad interactions between those systems. For example, we've got 5 providers, we've got 5 provider EPRs. They're probably our most expensive and complex systems that we own. They cost tens of millions of pounds per life of contract. Each constantly evolves. Each has got a big specialist team managing and updating all of those, and they get regular updates with new pathways, flows and capabilities. So imagine if we could reduce the numbers there. Imagine if we could remove our systems, reduce from 1,000 systems to perhaps 500 or less, with digital teams having more time and scale to focus on patient, workforce experience, on system-wide clinical pathways, data quality, and removing unwarranted variation. And if you can improve your data quality and drop your variation, the power of your data goes up. So that's going to be really important for help us understand and improve our patient flow, safety, inequalities, operational delivery, clinical pathways, to support clinical and scientific research, to generate and validate new AI algorithms, to translate research and discovery back into direct care. This will all be supported by an ICS-wide data lake, trusted research environments, allows us to collaborate safely, ethically, and appropriately with academia and industry. I think it will actually transform the way we work with academia and industry. And all of this is going to be supported by high-performant, resilient infrastructure that can be procured at scale, with teams able to support one another to ensure effective maintenance. Finally, if we get this right, it will be a place that can support our staff to thrive, to develop new skills, to innovate and optimise, and one that attracts and retains new talent. Thank you very much.
Thank you, Stephen. Thank you. That's very well put. Okay, I'll open up for questions. Jim first, then Sheena, and David. In that order, thank you.
Okay, I've got a couple of comments, really. First one, Kevin touched on it. We need to make sure that whatever we're coming up with is affordable. So there's a need to kind of work out, and you know, take the point about replacing hundreds of systems with a single system, there should be major savings. But I think someone needs to demonstrate that to us, and and this isn't. This is a direction of travel. It's a very well written document, by the way. So congratulations to the people who wrote it. I learnt a lot just reading this, so I think I found it very helpful in that sense. There's a sentence at the beginning which I just wanted to highlight, which says, the functionality and opportunity from digital and data initiatives evolve faster than we can implement solutions. That is such a well-written sentence, but it's the reason why the NHS has never actually managed to implement a single system. Because basically no one will wait for the slowest one to implement the system, so they all go their own way. This will need to be policed. If we're going to actually make this work, this will need to be overseen and regulated. And it may be through the Provider Collaborative Board, but there needs to be a lot of oversight of this to prevent people going off in their own direction. So that's kind of one of my points again. So affordability, that one. And the last bit is connectivity potentially is not just within Lancashire and South Cumbria. So depending upon how kind of structures go in the future, we may want to be connectable to the whole of the Northwest. It may even be bigger than that. So in terms of how this is all set up, it needs to be designed in such a way, and it may well be the case that this is easily connectable to other systems as well as Lancashire and South Cumbria. Thanks.
Yeah, we'll come back, Stephen. I'll come back with a few more comments if that's all right. Okay, I've got Sheena next, then David.
Yeah, thank you. I think I'd just like to echo what Jim's already said about it's a very well put together document and I think very clear. And I also think it's really helpful in terms of that overview about how everything fits together and particularly the slides or the pages 240 through to 249 about that, how everything gets, how we link together our priorities, what we're trying to do. So I think, and then the enablement that the strategy gives to those. I just wanted to particularly focus on the issue that we have around the fact that a lot of our population really do struggle. We've got a lot of digital poverty, and what we don't want to do is to leave those people high and dry when we move forward for this. And I was really pleased to see on page 289 under the population empowerment bit, and that's really been thought through as part of this strategy. So what we say is how do we bring those people and really focus and make sure that they have that access to all the benefits that this strategy could deliver. So thank you also for ensuring that's included within the strategy. Thank you.
It's a very helpful strategy, and I just want to apply a comment both to this and to the previous strategy, the workforce strategy. It's the so what question. What does it mean for our staff working in the ICB? What does it mean for doctors working in primary care? Maybe someone like somebody working on a ward. And I just wonder for both this strategy and for the workforce strategy, we could have a simple one-pager, it was referred to by a colleague earlier, something so that as we communicate with our staff, we can share something which is very simple and digestible about the strategic direction that the system is taking. Thank you.
Thank you, David. Aaron.
Thanks, Chair. I won't repeat other comments that have been made because I think they've been well made, including the reflection of the quality of the document, Chair. I think to Jim's point, this strategy has all of the opportunity to absolutely galvanise the quality improvement, service improvement and the financial improvement agenda. There are so many blockers to us progressing some of that collaborative and integrated working that are created by different systems, different policies, different ways of recording information, different ways of sharing information. It is possibly one of the biggest barriers we have to transformation. So to see some solutions laid out in a path like this with colleagues that have spent a long time thinking through it should be both congratulated and supported. And what I don't mean by supported is we sit at a board and say this is a good strategy, we support it. There's some practical support that I think follows. So when we're thinking about future capital investment priorities, I'd ask colleagues at the board and at the committees who will decide how we prioritise that investment to have this as a bellwether, to have a reminder of what the potential outcomes of investing in this area can give us. It can be hard when you do investments of IT in isolation. It's very difficult to get returns on investment for new systems, for example. But I think we need to continue to tether back to this strategy as a composite piece of investment, not piecemeal investments. I also think the risk of people stepping away at the pace of the slowest is an issue. We've seen that here in this system before. What I would say is the consolidation of systems is a joint committee decision by the Provider Collaborative Board. It locks in the 5 boards. We've also established one LSC with Steve as the digital lead. One LSC will be the corporate platform that executes this strategy from a provider perspective. So I think the collaborative is showing again that it's serious about working together. It's not just warm words. There are practical and kind of structural changes we're making to the way we lead the business in this space. So those are the reflections that I would give, Chair, but really support this piece of work, particularly as a platform for broader transformation.
Okay, thank you very much, Aaron. Tracy.
Thank you, Chair. Yeah, just to echo the comments, I really enjoyed reading this strategy. I thought it read really well. I particularly liked the emphasis on context, the spotlight on prevention, population health. I think it's great to see a digital and data strategy that really absolutely understands the context that we're operating in as a system. I think for me, the challenges, specific things that I can really relate to, that other people have mentioned as well, are around how do we resource this. It's massively ambitious. I think I've been around a little bit too long when we talk about Directory of Services. I remember very similar conversations more than 20 years ago about cracking this nut. Again, I think we've been tinkering around the edges of this. I think the strategy gives the impression that we're a lot further down the line with Directory of Services than we are. I think we really need to seriously think about the impact of having a really effective community-based directory that is properly resourced. And again, it comes back to that, I'm not clear. Kevin gave some clarity around the fact there's going to be really big investment in the NHS around data and digital. But what does that mean for us in Lancashire and South Cumbria? What does that mean for some of these really specific, where we're talking about the transformation within this that is ambitious, and what does that mean for a Directory of Services? Does it mean that finally we are going to see the investment that's needed? Because I think there is a real misconception that somehow you invest to set one up and then that's it, you don't need to carry on resourcing it. Simply not true, and we all know that, don't we? So yeah, I really welcome this. I also welcome the fact that there has been consultation across the VCFSE with this, but I think there needs to be more, far more, when we talk about how we implement what is a very ambitious strategy.
Okay, thank you, Tracy. Nobody else? Nope. I'll come back to you, Stephen, first, and I'll ask the Chief Exec just to complete you, Stephen. Thank you.
All right, thanks. There was quite a bit there. Thank you very much. I think the first one started about talking about that sentence that says the functionality is evolving faster than we can deal with, and nowhere else more so than the artificial intelligence. That's just accelerating enormously, isn't it? I think large language models only appeared about less than a year ago, and that actually we're really embedding those in our systems now, particularly in the well, we've adopted it in digital for coding. You can now use a large language model to tell you how to write a SQL query or Python code or stuff like that. That's used on a daily basis by our developers. It's massively reduced the learning barrier to implementing some of these things. But we've got to be really careful about implementing some of that. We can't put AI into clinical places unless it's been validated, and actually it's regulated by the regulatory organisations now. So it's going to be several years before some of these go, and there's a lot of snake oil in that place. We've got to be very careful. I actually don't think that it was due to the speed of innovation that we couldn't implement a single NHS system. I think you're referring to the a national programme at that point. I think that was down to the complexity. Trying to get just an organisation to agree on what they want for an EPR is hard enough. Getting an entire ICS is even harder. Getting the entire country, I think we found that was pretty much impossible. There's a huge troubles there. In terms of the connectivity, you're absolutely right, but if we can get down into the single systems, it makes it easier to connect out into the wider system. Doing our data, we're already working with the whole Northwest. We want to be able to have that population of 7.2 million patients across the whole Northwest when we're looking at cohorts for clinical trials, or when we're trying to understand our inequalities, or we're really trying to benchmark ourselves, and that's what we're already collaborating. We've got a £15 million bid that we won. That's revenue, by the way. Right across the system. So what, I think that's relatively easy to solve. I think that's just, there's quite a bit of data in here that we already show. So what does it mean for our people on the wards, in GPs? I think there's lots of stuff we can do in there, particularly in primary care, that we might not have highlighted specifically. We can bring that out onto a page. You're absolutely right about the directory of service. I can't answer that question specifically. I know there's a lot of work and I would really like to see that. Part of the resource, part of the problem of bringing people together is just having the resiliency in our teams. We have so many single points of failure in digital. Bringing them together helps to resolve a lot of that, and hopefully we can start to free some of that resource. Instead of having an entire team to manage every one of our EPRs, we can free someone to some of these other things that we really need to do in the system. Thank you.
Thank you, Stephen. Chief Exec.
Yeah, just 2 points really. There's quite a lot of funding already in the system here, and there's more coming as a result of the Chancellor's announcement, and there may be indeed more post a general election. I think the Chancellor's funding is coming on stream from April 2025. Probably the biggest challenge we've got is this is difficult to deliver. So it's actually, there's a real big delivery thing here, and a lot of that is not about the boxes and the cables, it's about people, isn't it? And it's about having the time to do that, so we shouldn't lose. Actually connects quite well to the earlier discussion on workforce in a way. It is about people, it's about behaviour and culture as much as it is about the technology, so we shouldn't forget actually installing these systems. Going to it'll be tough. We saw East Lancashire had some teething problems when they put the I thought they actually did a really good job in terms of delivery, but it is hard stuff. It affected thousands of people across the trust, so it's a big thing to do, and we can only do so much at once. So yeah, don't forget the delivery.
Go on then, David.
So I'm going to come back to my point once again, which is why the strategy isn't for this room, it's not for this board. Both strategies need to be shared out with our workforce to set that direction of travel, of expectation that we'll be working as one system to develop our workforce and for our digital solutions. It's just a very simple piece of work, but if we can work to inform our staff, we'll find delivery much easier.
I think that should be a given, quite frankly, David. All right, well, thank you. Okay, thank you very much for attending, Stephen. We're asked to endorse and approve the strategy. Board, is that agreed? Thank you very much. Again, thanks again to you, Stephen, for coming along this afternoon, and thanks to you, Dave, as well, Kevin. Okay. Okay, we're on to research and innovation, which I missed before.
Thank
you. Sarah, thank you.
Thanks, Chair. And I think this is probably a nice kind of bringing together of the themes, and particularly the previous two strategies. So just to remind Board, I brought a paper, I think it was in July, outlining our legal duties for research, which is new for ICBs compared to CCGs, and also NHS England guidance that had a number of recommendations, one of which was to develop a research strategy. The group that we set up following that meeting at Board took a decision, and it's a research and innovation group, so we've tried to bring research and innovation together. And just building on, Steve's still there, the group is connecting with our secure data environment colleagues, so we are trying to connect all of the agendas together, not duplicate and overlap. But the group decided that actually we already had a lot of strategies. We've got a number of national strategies around research, and that for this agenda, we didn't want a big strategy. What we would try and do was articulate on one page what the system needed to do and what the group could do. So really the paper is just outlining activity since I last came to Board, and it is asking for approval for the plan on a page. The collaborative, and there's a couple of people on the Board who are also part of the collaborative, I think it's a very vibrant, energised group that tries to connect. So this isn't about starting new or duplicating, it's trying to bring together all the different system partners who are already involved in research and innovation. And I got some feedback recently from one of our trust R&D leads that he's met people through that group that he would have never met before or connected with, and it's opened up opportunities for research within the organisation that wouldn't have been there before. So it's a very vibrant group. The plan on a page has come from the group. Even though I'm looking for approval today, I do see this as being iterative. One of the gaps on the group is possibly social care. We do have a professor of social care from UCLan who leads international research on social work and social care, but I think it would be good to get some more representatives from within our local authorities on the groups. That's something that I need to do, but I think it's quite an inclusive group, lots of partners there. And I see the plan on a page as, yes, some of those things are really important and we will deliver, we need to deliver, but it's as much a vehicle for corralling the system on this really important agenda. I see research and innovation as being the driver for better outcomes, but also back to some of our workforce challenge. There's lots and lots of evidence that a research, vibrant organisation, whichever sector they're in, actually the well-being of staff is better, and you recruit and you retain staff much better who have opportunities around research and innovation. So I think it's probably a nice bringing together, and actually digital and data, the work that the Secure Data Environment Group are doing and colleagues are doing massively opens up the opportunity for research. So they were my main comments. I probably would want to draw our attention. I couldn't list, what I'm finding since we're doing this work is the ICB is getting asked to be a part of more and more research, which is really, really good. But I wanted to particularly pull out the work that we've done through the WREN programme, which is summarised at 3.5.2. That's a national programme, but we've engaged and we've worked with Cheshire and Mersey on this. It's been really, really powerful work. It has driven some really small but very important research projects in some of our most underrepresented communities, and that programme is also about equipping our third sector and voluntary sector to be able to engage in more research. That's been really, really important. And also, and I would say this, but I think we've also growing a real energy in Lancashire and South Cumbria around the NMAP agenda, the non-medical research agenda, and actually I lead on that agenda now for the North West, and I'm engaging with the national team. I think there's real opportunity. We've got a number of our staff coming through our organisations who have secured NIHR grants to become senior research leaders, and also recently we had a nurse from East Lancs Trust and from within Chris's organisation who recently secured grants on the Clinical Research Practitioner Awards from NIHR. So I can see the staff coming through who could be our clinical professors of the future, could be our joint posts with our university, and I think that's a really, really important opportunity. So we're looking for approval of the plan on a page, which did go through Quality Committee, and I'm happy to take any other comments and questions.
Okay, very, very clear. Thank you very much. Yes, I've got Jim, Craig, and then Jane. Yes, and then Kath. Jim first, sorry.
Thanks. It's great to hear your enthusiasm for this, by the way, because this subject which has always been close to my heart, this. What I'm not sure, and this is me, what is in and out of scope for the ICB? So what is it we are responsible for, and what aren't we responsible for across the patch? Because we've also got these, like forget what they call, like the Mersey Coast one and the North West Initiative and all that, and how they fit into this. So what is it we are doing? I recognise what you're saying about the NMAP. They are always very kind of enthusiastic and do lots of great work, and it's always kind of not regarded as highly for some whatever reason. I think it's great that that's come to the fore in this. So I think it's good, but I'm not quite sure what it is we're supposed to be doing. So apologies, that might be me. And I'm really the only person in the room who doesn't quite know what's in scope and out of scope here.
Yeah, I think it's excellent to see here and the plan on a page, and I suppose it's implicit in this, and the vision is very clear about that improving lives for our communities. I suppose what it would have been good to see, and I don't know if this is what the group has also discussed, is that citizen-led research. So I know we talk about communities, but I was thinking that experience from Wigan and the Wigan Deal, a lot of that research that we found was from that real deep-rooted community approach to changing their lives, and how that generated its own evidence, and then we were able to lift that up at scale. So I know it's implicit in some of it, Sarah, so I just wondered whether that's something that the citizen-led sort of research and evidence component to it could just be a bit more visible in the plan on a page.
I'd just like to commend Sarah, really, for her work in this space, because your passion does come through. And, you know, you talk in the report about lack of resource, so to do this without significant resource is really commendable. I just wanted to emphasise just how important this is from so many different perspectives. From a staff perspective, if we in Lancashire and South Cumbria are known as an area that works on high quality research and innovation, we will attract talented researchers and talented staff members into our area. They will want to come and work here. Once we're on the map, and we can be on the map in a way that is quite unique to Lancashire and South Cumbria. You know, we've got problems of coastal towns, post-industrial towns, areas of high deprivation, different communities of people. Those are all quite a unique map, and we can become a specialist and known for kind of researching in that area, and it will attract talent in. And for the people who work in our organisations, it will enrich their jobs to be engaged in research. It will enable them to develop their careers, and they will stay and progress. So I think the kind of workforce thing in terms of talent and progression shouldn't be understated, but also in terms of, you know, what can research and innovation do? Innovation is about implementing solutions. You know, it links back to the digital strategy. What digital and the you know the patient story we heard at the beginning. What innovations can enhance care for our population? And you'll learn that through research. So the kind of whole transformation agenda is linked to this. We have some excellent universities on our patch. We're very lucky, and they can bring research funding in. So there's a big potential for this to be actually an income generator in terms of research income. And ultimately, all of this will link back to better outcomes from our population. So I can't. When finance is tight, the things that tend to go are research, innovation, and training, and they're all the wrong things to go, in my view, because they're all the things that have the potential to turn things around and address the problems we have, particularly beyond the near term. So thank you, Sarah, for keeping this on the agenda. And I love the map on. The strategy on a page is terrific. The other strategies have been good today, but they've been very long. So to get a map on a page is very good. Thank you.
Thank you. Yeah, so just to, same comments really, just to really commend Sarah. And I think there's, with the innovation stuff, if I think about your comments as well there as well, just about coastal towns. So there is already work underway in some areas, isn't it? So I think about Barrow. There's a lot of energy and resource at the moment in around Barrow, and there's significant numbers of people wrapped around and working with that. So I think it just goes back to what's the golden thread here. So we're not duplicating anything. We're building on what's already there. So yeah, happy to support and happy to link outside Sarah.
Thank you, Chair. Yes, I'm a bit biased because I sit on the group, and it's great to work alongside Sarah because I share her enthusiasm for research as somebody who was recently an NIHR pre-doctoral fellow. So I've done quite a lot of work in the voluntary sector trying to build capacity around research. I think just going back to Craig's comment, absolutely, about, you know, citizen-led research, it's one of the objectives, it's one of the things that we've delivered through the REND programme, which brought in investment, and we're looking to do more of that. I think wonderful to hear Jane as well, and your enthusiasm for this. I absolutely agree with you. It is an area that often goes when money is tight. I think what we're doing across this group with this plan is positioning research and innovation so that actually it can't go, because we recognise how important it is for the future of all the things you've outlined and everything we've talked about today, whether it's data, digital, workforce, absolutely vital. And I think as well, we've got some really unique things. Kath talked about Barrow, the work that's happening within coastal communities, the Health Determinants Research Collaborative that we've got in Blackpool, which again, you know, is producing a huge amount of research around lived experience, which is going to feed into a lot of the work that we do in the future, whether it's around UEC, whether it's around delivering things in a different way in our communities. So absolutely 100% behind this, and I'm so pleased that it's coming here to board and getting that high level support that it needs. Thank you.
Okay, thanks everybody. Nobody else has indicated, so back to you, Sarah.
Yeah, I'll try and respond. I think in terms of in scope, I think our biggest role is a system leader in this, Jim. So remember the guidance I brought, and the thing is around, the ICB had a responsibility to set up a system group, bring the system together. So I'll come back to the clinical research networks in it. So I think it's a little bit vague in a bit of that guidance, but it really, I see, and what I'm trying to do is that system leadership role. It's absolutely not about reinventing wheels. So, you know, we would connect with the work in Barrow to learn from it, but not kind of try and do some separate research in Barrow on that same agenda. That's what I was trying to bring out in the paper. So what we've tried to do is corral the system, but by bringing partners together, building on Jane and Tracy's points, you can then do bids together that are whole system bids, and you can actually attract more money into the system because you go for bigger grants, you go for it in partnership rather than say one trust or one partner going for a bid. And we've got a couple of examples of that. So I think in the paper I included some work we've done with Edge Hill around with the Arts Council, and that's a bid that is focused around mental health. But the fact that we collaborated with them as an ICB and we brought a trust together was probably made it a stronger bid than if we'd have bid on our own. So I think our scope is around that system leadership, but then it is around trying to build capacity and capability across the system to build on everything that Jane said. What we do have to do, though, is particularly primary care. If some of our practices are opening up new studies, they used to write to CCG sometimes for what you call R&D approval. And actually, that's why I've talked in the paper about a panel we've set up so that those smaller organisations on the patch who might want to do research, they might look to the ICB to approve it, and there we might endorse it. So we've set a panel. So there is a little bit of approvals responsibility for us on certain studies, not for the trust because they've got their own infrastructure and they will do that, but for some of our smaller organs. So we've recently had a study come through for a care home who was looking to us to support and approve because it might have affected some of our meds management staff because the research was around that. So I think the scope is system leadership and some approval. The research networks, you're absolutely right, they are NIHR research networks, so they're all funded through the National Institute for Health Research. We were part of the North West Coast, and then Manchester had their own network. Those two networks have come together in the last few months, so there's now a North West network. It's an NIHR network. It's their responsibility to open up bigger studies that our trusts might apply to be part of, or some of our practices, and they'll do recruitment into NIHR studies, and they're linked to the network. But the network also look to the ICB to support that work. So the network are on our group. The research network staff are on our group. So you are right, it is a complicated landscape, the research landscape, and I think honestly, NHS England and the NIHR are still figuring out some of their work that they're trying to do. But if you take my role, the NHS England Chief Nursing Officer has a team, and they expect the ICB Chief Nurses to be driving that non-medical research in their ICB. So we do have specific responsibilities, but I think the biggest one is system leadership. And just building on what Tracy said, I think it's just language, Craig. I think that community engagement and the REN work and that health creation bit is all where we saw the citizen-led research coming through. And the REN programme has absolutely been about building capacity for citizen-led research. And we've just had an email today, Chris, there's a new call on REN coming out around mental health. So some of your teams are copied in to that email. So there's another opportunity for us on that REN programme with a focus on mental health, which will be really helpful.
Okay, thank you, Sarah. So we just asked to note the research and innovation activity, approve the research plan on a page, and receive a further report at a meeting in 6 months' time. Happy? Okay, thank you very much. The agenda does say short break now, but I said before, I used the word called kind. Now I'm going to be unkind and not give you a short break and just carry on. So, sorry about that. And I'm going to take the new hospitals programme next. David.
Okay, well, let's make the rest of the agenda brief then. I'll take the paper as read, and this is simply an update from quarter 4, which is in other words from January to the end of March of this year, about progress with the new hospital programme. You'll be aware that there's proposal for 2 new hospitals to be built in Langston, South Cumbria, one around Lancaster, one around Preston. We don't know the dates that they will arrive, but I think we've begun to think it will be around about 2035. Paragraphs 3 outline the kind of key milestones to date, and in paragraphs 4 we highlight the work of the New Hospitals Programme, who are working on something called Hospital 2.0. There's going to be a whole load of documents that will be coming out to us through 24 and 25. Within the system ourselves, if you look at paragraphs 5.1, we've been realigning the governance to ensure, particularly for the ICB, we are prepared and ready to discharge our statutory responsibilities around public consultation as the plans are drawn up for the hospitals. 5.2 highlights that we're looking at potential new sites, and that work is ongoing, but no decisions have been made as yet. And in 5.3 you can see that the New Hospitals Programme team, particularly working closely with comms and engagement from both the two trusts and the ICB, have been working on to ensure that we have developed the appropriate resources so we can undertake pre-consultation engagement, which may take place later on this year. Of course, one of the key critical dependencies is if we have a general election at some point. So lots of hard work going on. You can see that probably within the next report there'll be more details about potential land acquisition, but at present progress is being made. Thank you.
Thank you, David. Comments, questions? Yes, Angie.
Sorry, I just need to declare a conflict of interest because the County Council does own some of the land which is part of the programme. Thank you.
Thank you. Any other comments, questions? No? It's for noting then. Thank you. Happy to note that. Yes. Much. Item 15 is the Lancashire South Cumbria ICB policies. You'll have noted that those now are there are links on the agenda on the papers. There's a number of policies there which Deb is just going to address now. Okay, thank you. Sorry, you want that? Sorry, you want that?
Thank you.
Oops, sorry.
So yes, I'll take the report as read. It presents 5 policies for consideration and approval, all of which are reserved to the board. Both the emergency preparedness, resilience and response policy and the business continuity policy have undergone a full and comprehensive review in line with NHSE EPRR core standard requirements and our role as a category 1 responder. All of the changes to those policies are set out under sections 2 and 3 in the report. The complaints policy, the section 106 and the standards of business conduct policy were all adopted at RCB establishment in July 22. So they've undergone a regular review. There's been some minor changes to ensure that they reflect our current working arrangements and any national policy requirements. And again, they're highlighted under section 4, 5 and 6 of the report. All of the policies have been reviewed by the relevant officers and executive or committee oversight where that's been appropriate, and they've all got a proposed review date of May 2027, subject to any further national guidance or policy changes.
Okay, thank you very much. Before I open it up, I'll just say that perhaps in future we might consider bringing these policies to the aligned committees that deal with these policies, and perhaps those committees then can take over the function of addressing or assuring the board that the policies are in a correct position. Is that happy? We're all happy with that? I think that sounds reasonable. Craig?
I know for emergency planning preparedness, it must be the board that sign it off. So I think I would agree. But where there are policies retained only for board sign off, they probably need to come. And I think they're small in number, but I wouldn't want to delegate to a committee and be outside of the core standards.
I don't think there's any intention to delegate. I think the intention is for the board to actually approve the policies, but for the to give us assurance. I think the committees to give us assurance that they've looked at the have a look. Oh, is that okay? Yeah, okay. Everybody okay with those? Happy with the policies? Yes, you approve those? Agreed? Thank you. Okay. Yeah, need to switch that on. I've not been made of any other business, other than to say there were 2 questions submitted to the board since it last met, and one was regarding the LD supported living registration, the other was in relation to a series of concerns within the local authority, and neither of those questions relate to items on the agenda, and those will be handled outside of the meeting. Okay, items to the risk register. Have we anything, do you think, risk register? No? Okay. Date and time of the next meeting is, oh yes, Wednesday the 19th of June, 10:30 a.m. to 11 a.m. Would you note that, because obviously that's now a morning meeting. Just remains for me to say thank you very much for your attendance, your contributions. Wish you all well, and I will hopefully see you again in the very near future. Thanks again. Bye now.